residency program director. His research focuses on clinical pharmacology in its translation to clinical practice. Dr. Macaluso is a graduate of Rutgers University and University of Medicine and Dentistry of New Jersey. So he's going to be our first presenter. Our second presenter is going to be Dr. Yogesh Dwivedi, who is the Elizabeth Ridgely Shuk Professor and also the co-director of the UAB Depression and Suicide Center in the Department of Psychiatry. Dr. Dwivedi earned his bachelor and master degree from the University of Allahabad and his PhD in biochemistry from the Central Drug Research Institute in Lucknow, India. He came in the United States as a postdoctoral research fellow at the Illinois State Psychiatric Institute and the University of Illinois at Chicago. He became a faculty member at the University of Illinois in 1994, and he joined our department in 2013. So this is a really very relevant topic because, as you know, we have a suicide epidemic in the United States. And it's difficult lately to look at any paper without mention of this important epidemic. So thank you for coming today. We'll have two presenters. We want you to participate and to ask questions. So without further ado, I'm going to ask Dr. Macaluso to start his presentation.
Thank you, Dr. Lati, for that nice introduction and for inviting me and Dr. Dwivedi to speak with this group. I'm going to share my screen. Can you all see my screen? Okay, I'm going to minimize the Zoom boxes so you can all see. So as a matter of housekeeping, I've received grant and research support from the entities listed. Dr. Dwivedi does not have any commercial support to disclose. I think it's important when we talk about suicide to start with a discussion of terminology. In fact, studying terminology as it pertains to suicide has become a major area of study. In fact, that area of study yielded the Columbia Suicide Severity Rating Scale, which is considered the gold standard for assessing suicidality in clinical trials. The Columbia Rating Scale is also now being used to assess suicidality in clinical practice. When I was at the University of Kansas, every patient who was admitted to the hospital was screened for suicidality with the Columbia. And then that screen would be repeated at regular intervals if they answered any of the questions positively. What the Columbia sought to do was use the right terms. So there was a problem in clinical trials where patients would display self-harming behaviors of some kind, and it would be mislabeled. For example, a patient might attempt to hurt themselves without the intention of killing themselves. However, that would wind up being labeled a suicide attempt. And so that was very problematic as we studied depression and suicide and tried to understand the data. So the goal of the Columbia Suicide Severity Rating Scale was to get clinicians to use the right terminology. And as I mentioned, that rating is now being used both clinically and in research. As I mentioned, it's important when we think about suicide to differentiate between parasuicidal behavior, which is sometimes called non-suicidal self-injury, and suicide, with the major difference being with a suicide attempt, the intent is for the person to die. So self-inflicted death is the definition of suicide. When we do a suicide risk assessment with patients, at minimum, we want to ask about ideation, intent, and plan. So ideation being the thought of wanting to die, intent being the expectation that the act is going to end one's life, and plan being the methods and means that would be used. I find that it's important to differentiate between suicidal ideation and morbid ideation. With morbid ideation, the patient wishes they were dead or has thoughts of death, but doesn't have the thought of actually wanting to kill themselves. Whereas with suicide, the thoughts are focused on desires to harm oneself with the intention and expectation of death. It's important when we talk about suicide to think about incidence and prevalence data. And so in most years in the United States, 30 to 45,000 people complete or commit suicide. There are over 250,000 attempts in most years in the United States. If you look at the suicide rate in the United States, it's about 14.5 per 100,000. That data is from 2017. That places the US at about the midpoint worldwide. Scandinavian countries, like for example, Finland, tend to have the highest suicide rates. And that's believed to be because it's cold in those countries in the winter, and it's dark in those countries in the winter, which of course contributes to depression. Spain and Italy tend to have the lowest suicide rates in the world, and that's believed to be because of religion, which can be a protective factor. The number one religion in Italy is Roman Catholicism, and the number two religion in Italy is Greek Orthodox. And in either case, suicide is considered a sin. And so in those cases, religion is believed to be a protective factor. Not to mention that the weather in Spain and Italy is generally favorable in the winter. This is our local Alabama data, and suicide is the 11th leading cause of death in our state. And so in any given year, between 800 and 900 people in Alabama die by suicide. It was 834 in 2017. Our suicide rate in Alabama of 17.1 per 100,000 is higher than the national average, if you remember the numbers from the previous slide. In fact, since 1990, the state of Alabama has had a higher suicide rate than the national average. This slide really hammers this point home. Now, keep in mind, the data on this slide is from a different year than the slides that you'd previously seen. So we were previously looking at 2017 data. This data is from 2016. So you can see in 2016, 20 out of 27 counties in Alabama exceeded the national suicide rate. What makes this really scary data to think about is that Alabama ranks towards the bottom in the United States in terms of access to mental health services. In fact, both states that I have practiced in, Kansas and Alabama, have both had a situation where their suicide rates exceeded that of the national average, but their access to mental health care was well below other states. In fact, the state of Kansas received a D, a letter grade of D from the federal government last year in terms of access to mental health services. This data comes from the VA. It's a little bit old, but it illustrates some points. So in 2009, the suicide rate among males in the VA was 38.3 out of 100,000. Whereas among females, it was 12.8 per 100,000. So you can see the suicide rate among females at the VA is a bit below the national average, whereas the suicide rate among males is quite a bit above the national suicide rate. At the VA, military sexual trauma is believed to increase the risk of completed suicide. Military sexual trauma is a large area of study within the VA population now. Many of our veterans were traumatized sexually during their military service, and that leads to increased risk of suicide, substance abuse, and other mental health problems. This here is classic data that comes from the American Association of Suicidology. if you look at completed suicides, the most common method used is firearms. 51.6% of individuals who die by suicide use firearms. This is one reason why our national organization, the American Psychiatric Association, has advocated for things like locks on guns, including a fingerprint lock that would lock a gun until the appropriate fingerprint was presented. The number 2 most common method of completed suicide is by suffocation or hanging, followed by poisoning. We want to think about some trends in these data, and these first 2 bullet points are things that are often taught in medical school, that men commit suicide 3 times more than women, but women, on the other hand, attempt suicide 4 times more often than men. And this is believed to be due to the fact that men typically use more lethal or violent means like hanging or firearms. We also know that there is a bimodal peak in terms of suicide risk. And what I mean by that is suicide rates are rising the most in adolescents and older adults. So suicide rates are rising nationally among all groups, but the suicide rates are rising the most in adolescents and older adults, people over the age of 65. And when it comes to older adults, we know that medical illness as well as social isolation are strong risk factors. This is very striking data as well, which shows that older adults make up 12% of the population, yet they account for 18% of deaths by suicide. There is some additional data that suggests that suicides in older adults may be underreported by as much as 40%, meaning suicides in older adults may be attributed to other causes of death, which is an issue at the medical examiner level. Looking at trends in this data, older adults tend to attempt less than younger people, but they are more successful and they complete more often. You can see in the 65 and over group, the suicide rate is 15 per 100,000, which is a little bit above the national rate. And then when you get up to the 75 and over group, it's 17 per 100,000, which is above the national suicide rate. This is a graphic that I think is really helpful in understanding suicide as a clinical issue and as a public health issue. And so what this graphic, which comes from Current Psychiatry Reports, shows is that there are a combination of risk factors that lead to lethal suicide behavior. So functional impairment, psychiatric illness, which can include substance abuse, social isolation, physical illness and pain, and access to lethal means. Of course, there are other things that are going on as well, different personality characteristics, cognitive processes, life events, and one's culture, which also contribute to suicide risk. I'm going to talk a little bit about specific psychiatric disorders and the suicide risk associated with them. And then Dr. Dwivedi will talk about his research. As clinicians, when we think about suicide and suicide risk assessment, we're doing just that. We are assessing risk. And that risk is different in each patient. And so we have to think about each individual patient's specific risk factors. We have to think about their specific social situation. We have to think about their mental status. We have to think about their psychiatric diagnoses. And we have to come up with a plan to mitigate risk. With anxiety disorders, I often find misconceptions among clinicians that anxious patients don't complete suicide because they're too anxious. And when you look at the data, that's just not true, that individuals with panic disorder and social phobia make suicide attempts 20% in 20% of, 20% of individuals with panic disorder and social phobia make suicide attempts. So that's pretty striking data when you think about anxiety disorders. In fact, 1% of all individuals who complete suicide had a diagnosis of panic disorder. Having both depression and anxiety at the same time increases one's risk for suicide. In fact, psychic or mental anxiety is one of the top 10 greatest risks for completed suicide. This is when individuals are ruminating or having mental anxiety. 50% of all persons who commit suicide have major depression. In fact, 15% of depressed patients die by suicide. So I think about this as depression being a malignant illness. And so I tell students and residents all the time that if you treat enough depressed patients, it's not a matter of if one of your patients will eventually die by suicide, it's a matter of when. And so we need to be thinking about suicide risk assessment in each and every patient we see and trying to minimize risk factors. Neurocognitive disorders and suicidality is an active area of study. In DSM-4, we use the term dementia. In DSM-5, that was replaced with the term neurocognitive disorder. And that means things like Alzheimer's disease, for example. And so classic thinking tells us that individuals with neurocognitive disorders like Alzheimer's disease are at greatest risk for suicide in the beginning of the illness. And this is believed to be because they know what they are losing. So they are still cognitively intact enough to realize that they may die within 8 to 10 years, and they may have a significant decrease in their functioning. Haw and colleagues, which is doing a lot of research in this area, concluded that more research is needed in adults with neurocognitive disorders to understand suicide risk. It's just an area we don't have enough data yet. With schizophrenia, the classic thinking was very similar, that individuals early in the course of the illness were at greatest risk of completed suicide because, again, they realized what they were losing. They might be young adults developing a chronic and degenerative psychotic disorder. They're seeing their friends go on to college or get married, and that can lead them to develop depression or suicidal thinking. There's been some recent study by the Cascow group and others showing that this isn't necessarily true, and that there are risks of suicide in older adults with schizophrenia as well. With substance use disorders, the suicide rate is 20 times higher for heroin-dependent patients than for the general population. Having a diagnosis of alcohol dependence increases the risk of suicide, and 2 out of 3 individuals with alcohol dependence who complete suicide also had mood disorders like depression. More VA work is on PTSD and suicide. And so when thinking about PTSD and suicide, higher levels of intrusive memories predict risk for suicide. And so what this means is re-experiencing. So individuals with post-traumatic stress disorder often have intrusive memories or re-experiencing of traumatic events. And the more frequent and intense those intrusive memories are, the greater their risk is for completed suicide. Personality disorders is another area where I find that clinicians often don't understand the risk of suicide. And that, in my opinion, is because patients with borderline personality disorder have parasuicidal behaviors or self-mutilation, which is non-suicidal self-injury, so harming themselves without the intention of killing themselves. And so even though borderline personality disorder is associated with self-mutilation, individuals with personality disorder still have a 7-fold increased risk of completed suicide when compared to the general population. In fact, incarcerated individuals with antisocial personality disorder are among the greatest risk groups for suicide. Prisoners have the highest suicide rate of any group. Now that we've talked about broad data on suicide and we've talked about suicide risk with specific psychiatric illness, let's talk about some interventions. And so much of the intervention work in suicide has to do with increasing connectedness. So we know that people who feel less connected to other people are at increased suicide risk. In fact, this has been talked about recently, relative to the pandemic and during lockdowns. You also hear about this in older adults who tend to be more isolated, which increases their suicide risk. And so there are some studies out of Japan where they took people with depression and they actually interacted with them by phone, they interacted with them by text message, and they tried to increase their feeling of connectedness. And the more connected that these individuals felt to other people, the less their suicide risk. The Prospect trials are quite similar and from the United States. And here they used a 3-tiered approach. So here they had an intervention involving care managers, involving algorithm-based medication management and interpersonal therapy. So these individuals each had a care manager who would reach out to them regularly. They would see a psychiatrist who would manage their medications using an algorithm, and they would have a social worker. So each of these individuals interacted with 3 professionals on a regular basis, interacting with the care manager the most. This increased connectedness and showed a decrease in suicidal ideation over a 2-year period. In terms of psychiatric medications, classically we know that lithium decreases suicide risk in individuals with bipolar disorder, and that clozapine decreases suicide risk in individuals with schizophrenia. There is new data on esketamine showing that it decreases suicide risk in depressed patients. In fact, esketamine is the first drug in history to receive FDA approval for suicidality. And so esketamine specific approval is for suicidality in individuals with depression. Esketamine is the first drug in history to receive such an approval from the Food and Drug Administration. This poster here was presented at a conference this past year, and you can actually find data on this in different psychiatric journals. It's actually based on data from UAB and Dr. Shelton's group and from my research group when I was at the University of Kansas. And so this could be a talk in and of itself, but what it shows is that with esketamine treatment, not only did symptoms of depression improve in individuals with major depression, but so did symptoms of suicidality, and so did suicide risk. So as a segue into Dr. Doveti's talk, how is our UAB Depression and Suicide Center working to help with this public health problem of suicide? Well, we're doing a number of things, including clinical trials of investigational treatments for both depression and suicidality. So you heard about the work we did with esketamine, which led the FDA to approve it for suicide risk and depression. There's also basic science research being done, which Dr. Doveti is going to talk about, and which gets into the genetics of depression and suicide. We're also collaborating with the Alabama chapter of the American Foundation for Suicide Prevention and doing some outreach to educate physicians and the general population on depression and suicide. And so I've always believed knowledge is power. That's one of the reasons why we do these talks, to give you knowledge, which can give you power. When you have that knowledge, it can help you in your own lives, it can help the lives of your family, and it can help people within your community. And so we're working with AFSP to share the knowledge that we have. I've listed our Depression and Suicide Center contact number here. If you have questions about clinical trials or research studies or anything that we're doing in the suicidality space, we would be happy to be a resource for you and for your communities. These are some other resources. If you or someone you know is experiencing thoughts of suicide, these are phone numbers that can be called. Of course, If your loved one is experiencing any medical emergency, and that includes thoughts of suicide, you can always call 911. So that's the end of my talk. As I mentioned, I think the goal here is to give you information on suicide as a public health problem, so you can use that information for the betterment of your community. And I'm always happy to be a resource to you and provide additional references and other materials. So with all that, I will pass the baton to Dr. Dwivedi.
All right, let me start sharing. So can you see that? Okay. Thank you, Matt, and thank you, Adrian, for introducing me. So as Dr. Macaluso pointed out, one of the goals of Depression and Suicide Center is to understand the fundamental mechanism at genetic level, why some people who have mental illness think of dying by suicide and some don't. Also, can we develop genetic markers that can identify those individuals who can or can't respond to treatment? So this helps in designing better treatment protocols and finding new targets that can be used to develop newer treatments or drugs. So I will go over a few ideas that our group has been pursuing in recent years. So when we talk about the vulnerability factors in suicidal behavior, as Dr. Macaluso pointed out, psychiatric illnesses are quite important factors. In fact, his data shows depression is one of them. But interesting point is that most patients with psychiatric illnesses do not attempt suicide. In fact, the data shows that although 50% of, for example, 50% of depressed patients show suicidal ideation, however, only 10% of the 10 to 15% of depressed subjects really die by suicide. So the question is, what determines whether a patient will attempt or die by suicide? And this type of research is going on currently at many centers. So one of the vulnerability factors is stress. And we all know stress plays a very important role in suicidal behavior. However, it is important to note that suicide is not a normal response to stress. It means that the stress in presence of psychiatric illnesses creates a situation where they can cause vulnerability for suicidal behavior. So what are those vulnerability factors we are talking here? There are three of them which are quite important. And as Dr. Macaluso also pointed out, that impulsivity, hopelessness, as well as suicidal intent, all three of them are quite important. A couple of them, impulsivity as well as hopelessness, are related to probability. So they create probability that the person will be thinking of dying by suicide. However, suicidal intent is directly related to lethality. So that always go in the direction of dying by suicide. So one has to watch very carefully a person who shows suicidal intent. So all these vulnerability factors, impulsivity, hopelessness, as well as suicidal intent, has some brain biology. And I will explain in simple terms in next few slides. So one of the features people have studied the brain of people who attempt suicide versus those who do not, although they have psychiatric illnesses. So this is one example I'm showing. This is fMRI studies done in these two populations. And there are two different brain areas you can look at. One is called dorsolateral prefrontal cortex. Another is ventromedial cortex. And dorsolateral prefrontal cortex is involved in risky decision-making, whereas ventromedial cortex is involved in social decision-making as well as emotional response. So as you can see here, these are the areas which are activated. So this shows the brain activity in these two populations. And you can see very clearly the people who attempted suicide has a greater activation in certain brain areas, particularly in ventromedial cortex, as compared to those who were non-attempters. Also, when people actually looked at the brain of people who died by suicide, and this is just a cartoon showing different types of cells in brain, they are neurons and glia, and they found that the structure of the neurons or those cells which are participate in brain function, their structures or numbers are different in people who are depressed or who die by suicide. And as you can see here, some of these cells are either smaller in number, and some of them, the structures are larger here. And these are the number of neurons are significantly lower in people who are depressed and who died by suicide. So obviously there are structural abnormalities in brain of people who died by suicide. As I mentioned earlier, stress plays a very important role in suicidality and how stress act on brain. So what happens that when a brain receives a stress signal, there is a specific area of the brain which is called hypothalamus releases certain hormones which communicates to another organ which is called pituitary gland. And pituitary gland then releases another hormone which reaches to adrenal gland, and ultimately adrenal gland releases cortisol. So this cortisol, these are the molecules which are released in bloodstream, and one can measure the level of cortisol. And once cortisol is released, this again reaches to brain to control the release of cortisol. So basically there is a negative feedback, a regulation happens between the cortisol released from adrenal gland and brain. In people who died by suicide or who show serious suicidal ideation or attempt, this negative feedback regulation of cortisol release is broken, and you see more and more cortisol are released. And one can measure the level of cortisol in blood and can determine the level of stress and relate to suicidality as well as depression. So when the level of cortisol, normal level of cortisol reaches to threshold, that is deleterious and can impact brain function as well as body function. So I won't go in detail, but I just want to show one slide, which is kind of a show that how stress can impact certain aspects of body or brain functioning. So when cortisol is released, it can impact the level of inflammation in brain as well as body. And you can see that the microglia, which is the type of cell in brain, which controls or which regulates the function of neuron, you will find that the people who died by suicide, these microglia are highly activated. And once microglia are activated, they release certain chemicals known as cytokines. And we all know these cytokines, some of them are pro-inflammatory, some of them are anti-inflammatory. But here, the pro-inflammatory cytokines are the ones which are highly released by microglia in people who are suicidal. And these pro-inflammatory cytokines then cause inflammation. And we all know inflammation impacts brain functioning as well as body functioning. So there are studies clearly show that microglia are activated, and also there's a release of cytokines and other inflammatory agents such as interleukins are high in patients who attempt suicide. There's another aspect of suicidality, which is chemical imbalance. And this is a very old theory, but it's still valid. And majority of the antidepressants which are prescribed to patients are based on this hypothesis. And this hypothesis is that the chemicals which are present in brain, particularly two of them, serotonin and norepinephrine, their release impacts mood. So under normal condition, you find that serotonin and norepinephrine are released, and they regulate the normal functioning of brain as well as mood. However, there are several research show that if the level of serotonin is decreased, then it creates depressed mood. We have done a large-scale study in patient population who had depression, bipolar disorder, and schizophrenia, and measured the level of serotonin as well as norepinephrine, and also these patients who showed suicidality or attempted suicide. What we found that people who had schizophrenia, bipolar disorder, and depression all showed much lower level of serotonin. But people who attempted suicide showed much greater propensity or the level of serotonin in blood. We measured that in platelets of these patients. And we actually predicted the suicidality rate based on the level of serotonin, and found that you can predict suicidality among these patients by 80% accuracy. So the level of serotonin and norepinephrine clearly reflect not only just the mood, but also suicidality. This is one slide I wanted to share, and it's quite important, which shows how, what kind of abnormalities you can expect in a person who died by suicide. And this is a brain, the neuron showing from a teenager, a 17-year-old who died by suicide, and the one who died naturally. And you can see here, this is a neuron, and we actually stained with serotonin. So you can see that serotonergic activity is much higher in a person or that subject who died by suicide compared to the healthy subject. And we also confirmed that by other technique, that serotonergic activity is much higher in suicidal subjects as compared to healthy subjects. So how serotonin controls various vulnerability factors? So it has been shown that if the serotonin level is low, it is directly proportional to seriousness of aggression, and also can predict future aggressive behavior. Also, low serotonin function modulates intent and impulsive aspects of suicidal behavior. So serotonin level is directly related to aggression, intent, as well as impulsivity. On the other hand, if you see the level of norepinephrine is lower, it is directly related to hopelessness or despair. So both these chemicals affect mood by targeting different vulnerability factors. In fact, a hypothesis has been suggested, and which is proven to be true, that how these two chemicals can impact suicidality. So what happens that if someone is depressed or showing psychosis or psychiatrically ill patient, and if any adverse life events occur, that leads to hopelessness, and that is related to low norepinephrine. But these patients who show low norepinephrine or hopelessness, although they show suicidal ideation and they start planning to attempt suicide, but they really do not go for suicide. In fact, serotonin plays a very important role, which regulates impulsivity. So at subjective state, for example, if someone is thinking outside the box or not based on the facts, then you will find the low serotonergic activity, which leads to impulsivity and suicide, that leads to suicidal act. So it is the combination of low serotonergic as well as the norepinephrine activity that ultimately culminate at suicidal act. And alcoholism, smoking, as well as substance abuse, they contribute to low serotonergic activity and ultimately impulsivity and suicidal act. One of the factors I just wanted to briefly mention, also what we are doing in our lab currently, looking at the genetics of suicide. Genetics play a very important role in suicidality. Studies show that about 4 to 10-fold increased risk for suicidal behavior in first-degree relatives. Also, there is a 50% increase in the risk for suicidal ideation or attempt compared to offspring whose mothers had never attempted suicide. So these genetic factors are quite important and show how genetics play a role in suicidality. And interesting point is that this familial transmission of the genetic factors, they are independent of psychiatric disorders or illnesses. So regardless of psychiatric illnesses, if those genetic factors are present, they can lead to suicidality in offsprings. So how to capture these genetic markers? So in our lab, we are testing a new way to identify suicidality and treatment response using these genetic markers. I will explain in a kind of a layman terms, but there's a lot more research going on in the lab. So one of the genetic markers we have identified, they are called microRNAs. These are small, tiny molecules which regulate the protein synthesis. The protein, we all know, is quite important for brain functioning as well as body functioning. And these microRNAs bind to another genetic material called RNA and regulate proper protein assembly or synthesis. So these microRNAs are highly responsive to environment, for example, stress. So if someone is stressed and you measure the level of microRNAs, you will see dynamic change in the expression or level of microRNAs within few minutes. Also, we have published several papers showing that these microRNAs are directly involved in causing certain diseases, particularly depression and bipolar disorder, and to a certain extent, schizophrenia. So this is one example I'm showing here. We published this paper a few years back, where we looked at the brain of people who were healthy and the people who died by suicide, and looked at the level of microRNAs, how the tiny molecule, the tiny shades you see, they are microRNAs. So we looked at how these microRNAs communicate with each other to regulate protein, and we found the level of communication is sparse in people who died by suicide versus those who were healthy. Also, we have published several studies where we were able to identify individual microRNAs which are involved in suicidality, and some of them are quite specific to depression, schizophrenia, and bipolar disorder. So these are the brain data, but then how can we capture this type of the data in patients who attempt suicide? Sorry. So, sorry, looks like the flicker. Okay. So one way to look at that, if possible, if we capture the events happening in brain and in blood stream. So fortunately, the microRNAs which are present in brain, they are encapsulated in small vesicles. They are called exosomes. So when microRNAs are released or activated, they come into these small, tiny vesicles. And these vesicles have capability to be released into blood, and they can cross blood-brain barrier. And we can actually capture these vesicles and study the microRNAs which are residing in these vesicles. In fact, we have devised the technology, and this is the first of its kind, where we were able to capture those small vesicles which are coming from brain in blood. So this is a simple diagram which is showing that normally we get blood samples for a patient population, we isolate plasma, then by differential centrifugation, we capture those small exosomes with a special technique we have. And once we have those exosomes or vesicles, we purify them, and then we tag them with a specific antibody which recognizes only those vesicles which are coming from brain. And then we isolate RNA, and then we subject them for sequencing, and we analyze the data. And this is the typical data we receive under different conditions. So I'm just showing the 4 different conditions here in example that you can identify what microRNAs are being expressed or not expressed under certain conditions. So you will see here, these are individuals where we looked at microRNAs, And these are different types of different microRNAs. You can look right here. Also, these are the individuals where you will find either they are stressed, non-stressed, suicidal, non-suicidal, and you can see here they are clearly different among different populations. So you can capture how these microRNAs are being synthesized, and and you can eventually look their functions too. I will give you just a couple of slides example here how we are trying to assess the level of microRNAs for their role in suicidality as well as treatment response. So this is one example. We are recruiting subjects who attempted suicide. And these subjects then get ketamine, as Dr. Macaluso showed that ketamine is very effective and anti-suicidal. And you will see the very rapid effect of ketamine in suicidal patients. So we are collecting blood samples at baseline and also after ketamine infusion at different time points to see the level of microRNAs being expressed or released at different time intervals. So this is the typical response normally we see when patients receive ketamine. And this is depression inventory score, and this is suicidality score. So in these, the patients who attempted suicide, you see there's a very high level of depression inventory score, which is close to 38. When you give ketamine to these patients, you see a very rapid response, and you'll see a drop in depression scale right here within 60 minutes. It remains almost constant over 24 hours. It goes back here at 14 days. Similarly, you see here within 30 minutes, very rapid response of ketamine and in suicidality scale, which remains constant for 24 hours. And it goes a little bit up here 14 days, at 14 days and 2 weeks. So what we did actually, we not only looked at the clinical response, but also the level of microRNAs. And this slide shows the dynamic nature of microRNAs. So when we looked at these microRNAs at different time points, you see there is a shift in microRNAs at different time points and different intervals after ketamine administration. So based on, I'm just showing the cumulative data here, based on our microRNA response to ketamine, we categorized 3 different groups of microRNAs. So group 1 microRNAs, actually they were highly responsive to suicidality. And you see here, there's a rapid increase in the level of microRNAs in people who were suicidal, but these microRNAs did not respond at all with ketamine treatment. When we tested the group 2 microRNAs, you can see here very high level of microRNAs in suicidal patients going rapidly right here after ketamine treatment, and then going back to the level close to suicidality, although not at the same level, but it's still at half. Then in group 3, you see a very rapid response again with these microRNAs with ketamine. And there is a slight increase in microRNA right here, which is very well correlated with the clinical response. So based on these 3 microRNAs, one can identify which microRNAs are involved in suicidality, which microRNAs are moderately responsive to ketamine, and which are the ones which are highly responsive to ketamine treatment. So this type of data actually is quite encouraging, and which suggests that not only you can identify the genetic markers which can show at least tell us the suicidality, but also you can measure these genetic markers and see which patients are responding to the treatment. In fact, these microRNAs are currently being used as a target for treatment also. So not only just the marker for disease pathogenesis or treatment response, but they are also being used to treat the diseases, particularly neurodegenerative disorders, some neurological disorders, as well as cancer. So these microRNAs are being encapsulated, and they are being targeted right at certain places where you see the level of microRNA is either low or high. And you can replenish by injecting those microRNAs right at the right place. And you see the functions of those organs or that particular system are being restored. So we have done that in animal model system, which I'm not showing right here, but you can restore certain behavioral functions by directly injecting those microRNAs into brain. So these type of studies are quite encouraging, and we are continuing to do that. So altogether, I would like to summarize that patients at high risk have predisposition on vulnerability factors, which are quite important. And biological identification and reduction of the predisposition will reduce risk. And most importantly, suicidality and treatment response can be identified at a biological level. So I'll stop at this level, at this stage, and if you have any questions for us, please ask.
Thank you, Dr. Dwivedi and Dr. Macaluso, for really absolutely outstanding presentation. So we have time for a question from the audience. So please you raise your hand if you would like to ask a question to either Dr. Macaluso or Dwivedi. Do I see anybody? You can also, if you have a question, you can use the chat.
One thing, Adrian, I might add, while folks are thinking about any questions they might have, there was a recent article in the Psychiatric Times about this new phone number. I don't know if you or Dr. Dwivedi saw this. It's 811. And so that is an initiative of the federal government that was advocated for by the APA. So individuals in crisis, when this opens, will be able to dial 811 to receive support. And so I think that's a great public health initiative to address what has become a very difficult public health problem with suicidality and other mental health crises.
Yeah, thank you for mentioning that. So the idea is that it's a number that is easy to remember. Yep. Because the hotline is not especially easy to remember. Is that correct?
Yeah, that's right. And it will get people to resources specifically for mental health crises, as opposed to 911, which is very general.
Right.
And so I don't remember offhand when this is going live. It may not be until 2021.
Yeah.
But
probably early 2021, AFSP initiated that process, and it went through legislation. So now it has been passed through Senate, I believe, and then now probably it will be active from January or February, something like that. Yeah. So that's what I heard. Yeah.
And also, I think it's important, Dr. Macaluso, to mention that at UAB, in the Department of Psychiatry, we are offering ketamine treatment.
Mm-hmm. Yeah, we have a nasal esketamine clinic where individuals can receive intranasal esketamine, which is FDA approved for depression and for suicidality associated with depression, as you heard. We also have a number of research studies looking at both esketamine, the nasal spray, and then the traditional IV ketamine. And so those are all things that can be accessed through our Department of Psychiatry and our Depression and Suicide Center.
I have a question for Yogesh. You had a slide that said that 50%, there was 50% increase in suicides if the mother had any depression. But what about the father? What about the contribution of the father's genetics?
People have studied and found that it is more linked with mother than father, and it is more with the maternal link than paternal. Somehow it is strange, though. I mean, if you look at, there are sex differences in how we perceive suicide. Women are more if you look at the suicide rate, it is higher in men, but again, women try to attempt suicide more than men. But this genetics is quite different. Actually, shows that it is more linked to maternal side than paternal side, which is kind of I don't know why, but that's how the data is.
Well, I know nothing of genetics, or almost nothing of genetics, but if it's really down the maternal line, I mean, could this be mitochondrial?
It could be mitochondrial. In fact, that's a pretty nice question. We have just started looking at the mitochondrial genetics in suicide. And the data shows that it is highly linked to mitochondrial genetics, which is, again, through maternal. So there is a possibility, yes.
Any other question or comment? Okay. Well, thank you very much.
I have one more. Okay. What can you say about the effects of COVID on suicide? Because all of the data presented was from 2017, and I know it takes years to get comprehensive, statistically accurate data. But what are the effects of COVID?
Yeah, there have been some prominent articles in journals like JAMA and the New England Journal of Medicine about rises in substance abuse rates and rates of suicide during the pandemic. And so people have talked about things like lack of connectedness, like I talked about, which increases suicide risk. And so, yes, especially during the lockdown phase of the pandemic, there were rises in suicide rates.
Also, I would like to point out there was an article published right after COVID in JAMA Psychiatry, and those people actually had looked at not this COVID-19, but other viruses and impact on depression. And what they found that the COVID increases inflammation and inflammatory response. So they have found higher levels of cytokines, interleukins, in those subjects, and there are a lot of data actually show direct relationship of inflammatory response to suicidality or depression. So it seems that COVID-19 is also going to impact inflammation or inflammatory response, which again will be linked to depression or other psychiatric illnesses.
Yeah, that's a good point, Yogesh. As psychiatrists, we always think bio, psycho, social. And so I talked about social and psychological reasons why suicide might be on the rise because of the pandemic. Dr. Dovedi talked about a biological reason. You know, with depression, we've long talked about the inflammatory and neurodegenerative hypothesis. There's this subset of depressed people who have elevated levels of inflammation. Said another way, there are at-risk people where if they have enough inflammation in their body and it crosses the blood-brain barrier, they'll develop depression. Well, it turns out that COVID produces a massive inflammatory response in some people. And so if that inflammation crosses the blood-brain barrier in at-risk people, they could develop depression or other neuropsychiatric symptoms. In fact, I think some scientists have even thought that the inflammatory response with COVID has led to some of the severe outcomes we've seen with people who have had things like stroke or other neurologic problems related to COVID-19.
Okay. Any more comment, question?
Just one more silly question, just out of sheer morbid curiosity. We know that suicide is a complex mix of cultural, psychological, and of course, you know, chemical and hormonal imbalances can have a very powerful effect. Of all the drugs, toxins, poisons out there, is there one that more than any other really increases the risk of suicide?
I mean, Matt, you can give this answer, but I know that certain antidepressants, particularly fluoxetine, the one SSRIs, when given to kids, there are several reports, it increases suicidality in those kids. And it is because they impact the level of serotonin. But again, it is only, these are only in kids, but not in adults. So I mean, I don't know what the reason is behind that, but there are certain risks associated with some of the antidepressants given to kids, at least.
Yeah, it's an area of controversy. So the FDA has issued a black box warning for basically any drug that wants to call itself an antidepressant. And that black box warning applies to individuals 24 and under, and is based on some clinical trials data from the same population that shows a 4% increased risk of suicidality in people on drug versus a 2% increased risk of suicidality for people on placebo. And so the reason that that is controversial is that that data actually led to a decrease in antidepressant prescriptions, which then led to a rise in suicide. I also point out to patients and families all the time that we can split hairs about 4% versus 2%, but 15% of patients with depression die by suicide. And we know that if we don't treat their depression, we just increase the risk of death by suicide. So the FDA black box warning with antidepressants is something important to talk about with patients, especially when working with people who are under 24, but there is some controversy.
Yeah. Interesting.
Okay, we have a question in the. Okay. So the next Neuroscience Café will be on pain and addiction, and that will be presented by some UAB faculty who are part of a new research center, an addiction and pain center. So anyway, thank you very much for all of you to come tonight. We are happy to see you, and thank you for the presenter. It was really very good presentation. Thank you very much.
Thanks.
And hopefully we'll see you next month. So everybody have a nice evening. Goodbye.